I'm going to speak to you today about screening for cancer, and I'm going to cover a couple of different cancers to give you some perspective that I want you to have. But my goal is not to have you screen more or screen less. I want you to basically be smarter about all of this, be smarter about the information you get, be able to ask questions and get knowledge that you need to make good decisions. So that's my goal with this presentation. And if we look at the notion as to why screen, I think that the basic thing here is that treatments that are available for cancer aren't adequate to take care of people, that they don't have the cure rates that we would like, that we feel that if we were to go upstream, if we were to find the cancers earlier, we may have a higher success rate or perhaps be able to successfully treat a cancer with a lighter or less traumatic treatment. So those are the potential advantages there. And before deciding to screen, you need to find tumors that are perhaps more common, and we will cover what common is later on in this presentation. You also want to have a test that is accurate, that doesn't have too many false alarms. But you also run into situations in which motivating people may be a bit of a challenge. Ordinarily, when patients seek medical care, they know they need it. They're not feeling well. And they know that the care was successful because they feel better. And with screening, it is basically a bit of public health that is being introduced into the physician-patient relationship. Decisions that have been made because we have looked at the population as a whole, and we have found that if you screen a large population, some of those people will benefit. And so the benefit for a particular individual at a particular moment in time isn't there. And as a result, the motivations for seeking this care, the motivations to try to get people to line up and get a colonoscopy done may need to be a little bit more extreme to motivate people. And over time, a number of organizations have evolved to promote screening, to advocate for better legislation, to advocate for coverage and research. And as part of their profile, they try to motivate people, usually using terms such as saving lives and the like, which I will address in a little bit. But those are organizations intended to try to decrease death rates from a particular cancer or from cancer in general. And as a result, the way things are promoted to the public is such that things can sometimes get very emotional in trying to promote guidelines. And so I want to show you a 1-minute video here that makes the point. And I've anonymized the couple involved, even though they volunteered to be on TV, because I don't want to isolate them in any way. They are actually behaving as others would wish that the public behave. This is the result that people are looking for, and in my opinion, we need to understand this a little bit better.
Awareness Month, and the American Cancer Society recommends that most women get their first mammogram at the age of 40. It can be easy to put off, though.
Yeah, you can forget about it. Chris Tanaka sat down with a local woman who's using her own experience to show others how getting checked could save your life.
When you see or hear cancer, you think the worst.
Sarah will never forget the moment she found out she had breast cancer. She turned 40 in January, had her first mammogram in February, and after an irregularity was biopsied, she got the news in mid-March.
It came back as technically stage 0, but it's ductal carcinoma in situ, or DCIS for short.
In an instant, everything came to a halt for Alexis, her husband Tom, and their 4-year-old son.
I had a really hard time rolling that word cancer out of my mouth, saying like, I have cancer, I have breast cancer. Like, it still is jarring.
I just did a lot of crying because I was like, why can't it be me?
That's the issue. And I think that the term saving a life needs to be revisited. Saving a life is easy to conceptualize. The notion is you're either alive or dead, that your death is imminent. That is what the EMT does when they find you with your heart not beating. That is what happens in a number of instances where a fireman pulls you out of a burning building or the like. Those are instances in which somebody saves your life in that moment. But when we're talking about screening, when we're talking about finding cancers, when we're talking about preventing or delaying death from cancer, it's a different story. And I don't think that that terminology is that appropriate. And I don't think it's nitpicking to say that what we're talking about here is prolonging a life. When that term is used, my opinion is that it changes your focus. You're not talking about being dead in the next moment so much as you're talking about how much life, when, what are your conditions going to be of living after that. And that is really a more appropriate frame in which to think of these programs regarding screening. So let's look at what's at play. I'm going to talk about a little basic biology here and then give you a sense as to what makes cells normal. Why is a cell okay? And the fact is that cells talk to each other. They behave in an orderly way. They grow at a predictable rate. They stay where they're supposed to grow. They do not overgrow. They do not spread elsewhere. If in fact a cell from a particular tissue breaks off and gets into the bloodstream and goes elsewhere, it won't grow, or it will be recognized by your immune system and eliminated. And so it is that orderly progress that you see here, respecting boundaries, growing the same as its neighbors do, having a limited lifespan. These are the characteristics that are normal to our tissues. When something becomes cancerous, what we see is that those rules don't get followed, that it doesn't respect borders, that it may go through borders. It may break off and get into the bloodstream and grow elsewhere, not only grow elsewhere, but even stimulate blood vessels to feed its growth in that remote location. And these sorts of things where they grow faster, they last longer, they grow in places they don't belong, are the characteristics that make cells cancerous and the characteristics that make these cancerous cells kill you. So that is the characteristics that we're looking at. Other key factor is that when cells become cancerous, they don't necessarily progress in an orderly way. It is not as though they lose the boundaries, they lose the size that they grow to, and then finally they acquire the ability to grow elsewhere. They can acquire these traits at different rates and at different times in their own cycle. And so what researchers who look at cancers have determined is that different tumors have different growth characteristics. And for simplicity, they've divided them into three different categories of what they refer to as turtles, rabbits, and birds. And the blue line here, the horizontal line, is the point in growth of a tumor at which you can have symptoms. So you know it's there, you report it. And the goal of screening is basically to move you upstream from those symptoms to detect the tumor earlier. And over time, what has been found is that with the birds, even though we detect them earlier, they've already spread. Early in their cycle, they have spread elsewhere, and detecting them earlier has not left the treating physicians in a better position. The rabbits are how we typically think of cancer. It is something that grows, it gets bigger, and then finally it starts to spread. Finding those early is a good thing. It heads off the spread. And then turtles were essentially appreciated later in the cycle once screening became more common. And what you would see is that these tumors would grow. And what we've learned is that even though under the microscope they're invasive cancer, they weren't going anywhere. They weren't going to develop symptoms. They weren't going to kill the patient. And yet, not knowing better, we are obligated to treat them and subject the patient to a treatment that they may not have needed. So that is what has been introduced with these various tumors. Now, if we look at the screening guidelines that we have, the question becomes, well, what kind of guidelines do we get? Who determines this? How do they go about it? And for my money, the best organization out there is the U.S. Preventive Services Task Force. And this is a group of 16 individuals screened for conflicts of interest, known to be experts in their field. And they will meet periodically, and at the direction of a division of the National Institutes of Health, they will look at a preventive service and try to review the literature regarding what difference it makes. They will bring in testimony from experts in the field. They will open it up to testimony from the public. They will try to arrive at a guideline that they feel represents a certain level of the state of the art at the moment, and rate these as A, B, C, D, A being good evidence for good benefit, B, moderate, and C, weak evidence for weak benefit, and then D, potential harm. And within that, we have the guidelines there. It would be lovely if everybody agreed, but what we see is that other organizations, whether they're professional organizations of physicians or whether they're advocacy organizations, may differ a little bit. Usually the discrepancy occurs when the U.S. Preventive Services Task Force recommends something that is less rigorous than it had been. So they dial it back a little bit, and often this is met with objections from advocacy groups of one sort or another. But also, I would say that we're never free of politics, even though efforts have been made within this organization to insulate it to a degree. Nonetheless, these are appointees with 4-year terms. The person appointing them is themselves a political appointee, and so it can happen. And if we look, for example, at breast cancer, what we see here is that guidelines from 1997, where they basically asserted that screening women under the age of 50 may not be necessary. The Senate voted 98-0 not to accept their guidelines. In 2002, the task force then had some turnover in the interim. Different people were on the task force. They moderated it a little bit, saying that perhaps it is reasonable, and certainly this would trigger providing insurance coverage. And in 2009, the recommendation was for every 2 years from 50 to 74, so they put a top age on it at that point. And then under age 50, they went back to individual choice. They softened the recommendation a little bit. And as you can see, the Senate reacted negatively to that. In 2016, they recommended mammogram every 2 years for 50 to 74, and then basically under 50 allowed that it was a C grade recommendation, very mild evidence of benefit. And this again triggered responses. And in 2024, perhaps in an attempt to moderate the controversy, they bunched 40 to 74 together and gave it a B grade, saying every 2 years is reasonable for this population. So you can see how these have evolved. You can see that the group seems to keep revisiting the 40 to 50 age group, and that political factors have come into the equation as well. And if we look at the media, if we go back to the 2009 piece there, which was particularly loud and controversial, we see Joan Venacci, a columnist for the Boston Globe, responding very strongly in an article saying, thrown under the bus, rationing, why are women the first losers, death panels, the whole bit. But also in the Boston Globe, another columnist, retired at this time, Ellen Goodman, who herself comes from a family of higher risk for breast cancer, says that the benefits from mammography of younger women are being oversold, and nobody wants scientists to bow to politics. So a very moderate response, particularly from an individual who would be particularly interested in this guideline. And if we look at the New York Times at this point, also we see nearly every body part susceptible to cancer now has an advocacy group, a politician or an athlete, with a public awareness campaign. And yet these exams offer little benefit. So you can see the controversy that has been humming along, and it really continues to this day. So is there a downside to screening? Why not screen everyone? Isn't knowledge good? Isn't it a good idea to get that additional information? What harm is there? Well, the answer is that it may miss the disease. Not every screen is going to pick things up. And so you may have the false comfort of saying that you don't have a condition when in fact you do. It may not make a difference. You may be dealing with the birds, in which case the spread has occurred, you've gone through the screening, and your ultimate outcome has not been affected. There may be false alarms, and we'll cover that in more detail. And you may discover and treat disease that would not have harmed a patient. Again, we'll revisit this in a while. And note also that although you're looking for the more common cancers, that most most people don't die of that cancer. And so you are screening for a condition for basically a benefit to a minority of patients. And the prime benefit is for those rabbits, the ones that grow and then spread, and to which there is a benefit for finding them early. And so those are the ones that you really feel there's a benefit for. And when we're looking at screening, I think there are times when terminology makes a difference. There are times when the way things are presented makes a difference. And I'm going to show you an example here where in a given population where initially there were 10 people who had a particular cancer and one died, if you then introduced a screening test, which is more sensitive, suddenly you find that you've got more people with the cancer. So good thing you would introduce the screening test, because now the incidence of this disease is going up. And in fact, you've gone from 10 people having the condition to 20 people having the condition. But if you look underneath that, there's still one person dying. The cure rate has improved. 95% now are being cured, but the death rate hasn't changed. The number of people dying of this condition is the same, and it is that death rate, if you are thinking of benefits of screening, that you need to keep an eye on. You can be deceived by incidence of cancer. You can be deceived by cure rates, because mixed in there is the notion of detecting a lot of tumors, a lot of turtles that wouldn't have harmed anyone. So let's look at cancer of the prostate. And here we have a situation where we have grade C recommendation for screening men in the 55 to 69 age group. So mild evidence for mild benefit, and D, actual harm to screening men over the age of 70. That's the current state. When it first came into play, they were recommending screening everyone over the age of 50 at high intervals. They're currently screening at every couple of years as opposed to every year. The incidence of cancer of the prostate, which is among non-smokers, is one of the most common cancers in men, is about 1 in 8, 13%. However, it has long been known that there is underneath this an indolent incidence of cancer of the prostate that is there, that doesn't kill people. It has been known for a long time that if men live long enough, most of them will have cancer of the prostate. This has been found on postmortem examinations, and that most of them won't die of that cancer of the prostate. So that concern regarding overdiagnosis was in there from the start. And if we look at cure rates, if it is found in the localized stage, then the cure rates are extremely high, 99%. But with distant spreads, it drops to 40%. So the advantage of trying to find this distant spread cancer is important. And if we look at the number of men who die of cancer of the prostate, then it's about 2%. So 98% of men don't die of cancer of the prostate. And that means that if we have a major influence on that 2% death rate, the big picture isn't going to be affected all that much. And so that is a characteristic embedded in screening in general that we need to understand in making our judgments. There have been a lot of therapeutic advances with this cancer, as well as many other cancers, better immune therapies, better hormonal therapies, better surgery and radiation. And yet the years of life gained for this, and the reason for a C grade recommendation at best, is that it's debatable as to whether men would live longer if they undertook screening. And overdiagnosis, the idea of finding cancers that wouldn't have killed the individual, is high and getting higher with age. If we look at the incidence of cancer of the prostate, the light green line on top, you can see that with the introduction of the PSA test, the incidence came up. All of a sudden, there were all these men with cancer of the prostate, and they were undergoing treatment. Yet, if we look at the death rate, the dark green line on the bottom, you see that there wasn't much movement there at all. If you look into the 2000s or so, again, an appreciation of this overdiagnosis, the concept of active surveillance was introduced, where pathologists were able to look at a specimen, look for various indicators, and indicate that perhaps a tumor was less likely to grow and spread, and that it would be legitimate rather than subjecting someone to a major treatment, to observe them over a period of time and look for signs of growth. That active surveillance was offered as an option, and fortunately, it did not result in an increase in the death rate. It actually was accompanied by a decrease in the death rate, likely resulting from better treatments. And then finally, the idea of stopping screening at age 70, you could imagine that the incidence of cancer of the prostate was going to decrease because you're not finding them as often as you would. And the question is, did this do harm? Was there harm in not doing the test? And what you can see is that even though the incidence went down, the death rate did not go up as you might fear. So this is a curve that reflects the moderation over time, and moderation that appears to have paid off in good ways. If we look at cancer of the breast, again, we're looking at a B grade for recommendations, and 40 to 74 every 2 years, moderate benefit. Incidence about the same as cancer of the prostate. So we're talking about roughly 1 in 8 women getting clinical cancer of the breast during their lifetime. In general, a somewhat younger age group than we would see with cancer of the prostate. But again, a very high cure rate for local disease. And regional disease has a reasonable cure rate of around 85%. But again, once it's spread, you really wish that there was something you could do to interrupt that growth cycle and catch those before they have spread, and diminish the morbidity and mortality associated with metastatic disease. If we look at how many women die of breast cancer, it's a little over 2%. So over 97% of women die of something else. And therapeutic advances, immune therapies and hormonal therapies, radiation therapies being better, all of these things have led to better outcomes for patients. Years of life gain, though, and again, if you're looking at trimming down on something that kills under 3% of women, you can't expect to get too many years of life gained from that. But nonetheless, if looking at a population as a whole, you need to be aware of that component. And the concept of overdiagnosis, something that hadn't really been appreciated, the idea of turtles, the idea that you've got a tumor that grows and it's never going to kill the patient, it's never going to become clinically evidence. That is something which we became much more aware of once screening began, and can amount to at least 20% of the cancers that are found, even though the pathologist cannot, in an individual case, look at that cancer and say that this is a overdiagnosis. And again, if we look at a similar curve over the same span of time, we see that the incidence of breast cancer goes up with screening, but that the death rate from breast cancer, particularly in the 80s and early 90s, really didn't change. It doesn't change until you get into the mid and late 90s, when the introduction of much better treatments is brought into play. And this concept of overdiagnosis was focused on when analysts look at the incidence of breast cancer, and felt that roughly 30% of the increase was associated with the onset of screening. So a significant amount of that was due to screening itself. The other important thing in this graph here is that the number of cases that were metastatic at the time they were found is unchanged. So even though screening was introduced, the ones we really want to get at, the ones you want to get upstream of the metastatic disease, that does not appear to have occurred over this period of time. So I'm going to show you what happens. I'm going to put it in concrete terms regarding what happens to a group of women who are screened every year or two for cancer of the breast. And so this is 10,000 women. We're going to screen them every year or two from 60 to 69. And what we see is that roughly half of them will be called back for more views. There will be a false alarm. There'll be a concern that things are not normal. And of these, roughly 15%, 1,500, will undergo biopsies because the mammogram was indicative of the potential for cancer that couldn't be resolved with just imaging. Of these 1,500 women who have a biopsy, roughly 350, so 3.5% of women in this 10-year age span, will have cancer of the breast. And of these, not all were found by mammograms. So a mammogram is about 90% accurate. And what we find here is that we're looking at roughly 35 of these cases were found clinically as opposed to on mammograms. Also, it is estimated that overdiagnosis, and I'm using a 20% number here, which is fairly conservative in the literature that is out there. So roughly 70% are overdiagnosis. So they're people who will undergo treatment and who likely would not have died of the disease. If we look at why women die or how many women die, let's look at that same 10,000. And rather than watching them for 10 years, let's watch them for 15. So we get cancers that were found towards the end of that screening period, a little more time to take their toll. And what we find during that span of time is that a little over 20% of women will die of one reason or another. And within this, deaths due to breast cancer in a screened group would be about 90 women of the 10,000. And if they were not screened, an additional 26 will have died of breast cancer. So that, in concrete terms, are the best estimates that we have of the difference that screening mammography makes in a group. Now let's move on to cancer of the colon. And this is an instance in which the U.S. Preventive Services Task Force grade is A, good evidence for good benefit, particularly in the 50 to 75 age group. More recently, they have introduced the idea of screening people from 40 to 45, 45 to 50, but that is at best moderate benefit, and it is moving into the same sort of controversy that screening women in their 40s for breast cancer went through. And then for people who are over the age of 75, it is considered to be of minimal benefit in that group. If we look at the incidence of cancer of the colon, though, one of the more common cancers in non-smokers, we find that it's about 4% of the population. So 96% of the population is being screened for cancer of the colon. They're not going to develop cancer of the colon. We just don't know which of them are in that 4%. Cure rates, 90+% for localized disease. Regional is 75, but again, distant disease is something you really want to find a way to get at and diminish the incidence of. But deaths due to cancer of the colon are 0.4%. Over 99% of people do not die of cancer of the colon. That's important to know. And therapeutic advances are being made, which make a huge difference here, regardless of the stage that the tumors are found in. The years of life gained here are marginal for the population at large. And the issue of overdiagnosis, of finding tumors that would not have harmed the patient, is felt to be less of an issue with cancer of the colon. And there's an additional bonus with cancer of the colon in that precancerous changes can interrupt the progress here. And so if we look at a similar curve for cancer of the colon, what we find is that with the onset of screening, they were not only finding cancers at an earlier stage, but they were also finding precancerous conditions, polyps that were developing in the colon and which could be removed and therefore head off the development of cancer of the colon. So unlike cancer of the breast or cancer of the prostate, where suddenly the incidence of disease goes up, what we find is that the incidence of disease is trickling down because some cancers, as a result of screening, are being prevented. We also find improvements in the outcomes with regard to deaths. And I think a lot of this tracks back to the decrease in the incidence of disease that has occurred. So good signs here, and this is probably what is behind their grade A recommendation. And if we look at why people die or when people die, what we see here is that, and this gets back to this idea of saving a life versus prolonging a life, the morbidity and mortality of cancers occur mostly in old age. And this is a complicated slide with a lot of small numbers, but basically if you look at the furthest right bars, the three bars on the right, that's where the highest incidence of deaths from these three cancers occurs. And those are age groups over the age of 75. So we're talking about heading off death from a cancer in an age group which has a lot of competing morbidities that can be in there. So other causes that may prevent someone from dying of old age and just head off one cause of death. And if we look at this slide here, which is a busy slide, it's got a lot of information on it. There are some important points here I want you to see. This is looking at, for a population as a whole, years of life gained. And what we see here is that the line in the middle, the vertical line in the middle, is 0 days for the population, and that the diamond, which is the best average of the evidence that is available at the time, is what the average is for years of life gain. And those diamonds are pretty close to 0 for most of the screens that are here. And this is screening mammography for breast cancer. It's screening a couple of different tests for cancer of the colon, PSAs for cancer of the prostate. And they're on both sides of the line. The other thing I want you to see here is that those lines are very wide. There's an enormous amount of uncertainty in the world's literature. You would like to think that the literature that is out there is more definitive. You would like to think that when research is performed around the world by good departments and good research organizations, that they would address the same question and have the same answer. But in fact, there is a lot of uncertainty, and it is this uncertainty that the U.S. Preventive Services Task Force has to deal with in trying to make a recommendation for the entire country. So thus the hedging that goes back and forth, thus the uncertainty that is out there, and that is a significant issue here. And so what are the take-home messages from this presentation? Well, first of all, screening, I think, works for a lot of people. I think that if you understand that the delivery is of results here is more modest than it may be promoted as, that it is reasonable to undergo screening tests, that you can sort of pick your frequencies in some cases, and you may wish to modify that. And there are certain medical advances that I think are needed. Going forward, I think I would like to see us be able to look at our populations more specifically and be able to decrease the amount of screening that occurs. Perhaps after someone has a negative colonoscopy, they don't need another one for a much longer period of time. That sort of thing. We also need the pathologists to be able to look at a tumor and better determine whether this is a turtle or not, whether this is a cancer that can be safely observed as opposed to subjected to more radical treatment. And then finally, even with the most thorough review of the literature, there is a lot of uncertainty. And so we need to look forward to the funders of medical research being able to more precisely direct the kind of research that is done to enable us to get a clearer answer to these important questions that are out there before we recommend to tens of millions of people that they undergo screening, which could subject them to harms as well as benefits. And if you're trying to make a decision regarding getting screened for cancer, number of things. What are your chances of getting the cancer, particularly in the next 5 or 10 years? What are the chances of you being cured of this cancer if you weren't screened and it was just found? What are the chances of dying of the disease that we're talking about here? And what are the issues regarding false alarms for these screening tests? What are the consequences of that? And beware of media reports of the incidence of diseases going up. The first thing you should ask when you hear that is, have they changed the way they screen for the disease? And also that the cure rate is going up. And again, the first thing you should ask is, are they detecting a lot of disease there? Is the death rate actually changing, or is it that they're picking up a lot of turtles? So this is the framework that I'd like to leave you with this presentation. I hope you found it beneficial in understanding cancer screening. Thank you.